Let's look more closely at how these two dimensions account for considerably different styles of interacting with patients. Put very simply, we can represent the rapport dimension as 1. Treating patients with care and respect, or 2. Failing to do so. Similarly, we can represent the sense-making dimension as 1. Addressing patients' issues, or 2. Failing to do so. In combination, then, we can identify 4 different styles of talking with patients about health behavior change. Note that only one of these styles is MI. So let's consider the case of Geraldine Jones, a 55-year-old African-American female with a blood pressure of 150/100. She's talking with a 45-year-old healthcare professional about her high blood pressure. We'll examine each of the 4 styles of interacting to get a sense of just how much the interactional dynamics can change based on what you do on these 2 dimensions. Listen to this dialogue between Geraldine and the healthcare professional. See if you can figure out what is happening on the rapport dimension and on the sense-making dimension.
I don't know. I just don't think my blood pressure is that bad. Lots of people have worse blood pressure. And also, I just don't like taking medicine.
Uh-huh. Okay, well, it's your decision. You do need to take the medicine, though.
I know it's my decision. I don't want to take the medicine. Patients are prescribed too much medicine all the time.
Well, I sure can't make you take it.
That's right. I'll get my blood pressure checked again in 6 months, and we'll see what's going on.
Well, if that's what you think you'd like to do.
In this interaction, the healthcare professional fails to make any progress in either building rapport with Geraldine or in addressing her issues. Because the healthcare professional uses uh-huh and okay as substitutes for explicitly responding to the patient's issues and concerns, Geraldine has no idea whether the healthcare professional has heard and understood her issues, much less whether the healthcare professional even cares about her issues. There's little rapport with Geraldine. In addition, the healthcare professional doesn't address the patient's sense that her blood pressure is not that high and that she doesn't like taking medicine. As a result, issue resistance remains high. So, Geraldine is left on her own with exactly the same misguided sense-making that leads her to underestimate the seriousness of her situation. Left to her own inclinations, Geraldine won't do anything until her next blood pressure check in 6 months. One additional point. Many people who learn MI at a superficial level think that saying, "It's your decision," is MI. In the absence of reflecting the patient's issues in a caring and non-judgmental manner, and in the absence of providing information to address the patient's issues, saying, "It's your decision," is basically irresponsible. The patient is left to continue operating from incomplete information. This dialogue is extremely unproductive because it fails to build any rapport with Geraldine and because it fails to address her sense-making about taking medicine for her blood pressure. Okay, let's take a look at a different style of interaction that's based on creating rapport with the patient but fails to address the patient's issues.
I don't know. I just don't think my blood pressure is that bad. Lots of people have worse blood pressure. And also, I just don't like taking medicine.
You're thinking that your blood pressure is not all that high, especially since other people have blood pressures that are much higher. Not only that, you don't like taking medicine.
Right. Patients are prescribed too much medicine all the time. Besides, I feel okay.
You worry that sometimes medicine is prescribed that may not really be needed, and you feel okay, so maybe the medicine is really not necessary.
You got it.
That leaves you thinking things are really not that bad, and you don't need to take the medicine.
Right. I don't have money to spend on unnecessary things.
Seems like a waste of money at this point.
This healthcare professional does a great job of non-judgmentally reflecting the sense-making at the heart of Geraldine's issue resistance. Not only does the healthcare professional avoid losing face for Geraldine, It's also clear that the healthcare professional is working hard at listening to Geraldine's issues and concerns. Geraldine feels the rapport of being valued and heard by the healthcare professional. But nothing changes because Geraldine's issues are not addressed. She still doesn't realize that any elevated blood pressure is potentially dangerous. Also, the necessity of this particular medicine has not been addressed. Geraldine concludes that she doesn't want to waste her money because her sense-making and reasoning have not changed. So while reflecting back doesn't cause any face loss and helps to build some rapport, there's no further progress in addressing the issues. As a result, there's no need for Geraldine to consider any change. One last point in this case. With the absence of addressing Geraldine's issues about her blood pressure and the necessity of the medication, rapport building can actually appear to Geraldine to support her position that her blood pressure is not that high and the medication may be unnecessary. Let that sink in a bit. MI is not just about building rapport. We use rapport building so that we can address a patient's issue or misguided reasoning in a non-threatening way. Here's the third style of interaction that emphasizes addressing the patient's sense-making while ignoring building any rapport with the patient.
I don't know. I just don't think my blood pressure is that bad. Lots of people have worse blood pressure. And also, I just don't like taking medicine.
Other people's blood pressures don't matter. Yours is elevated, and any blood pressure that is elevated is potentially dangerous. You need to bring it down below 140/90 to reduce your risk of stroke or heart attack.
But I don't like taking medicine.
No one likes taking medicine, but it is absolutely necessary if you want to reduce your risk of a stroke or heart attack.
Fine. I'll get the prescription filled. I need to go. I'm in a hurry.
Okay.
This healthcare professional addresses Geraldine's issues but creates such face loss, both competence and autonomy, that relational resistance ramps up dramatically and any hope of rapport is lost. Consequently, Geraldine is unable to hear the information provided to address her issues. Competence face loss is created by the statement, "Other people's blood pressures don't matter." Autonomy face loss results from, "You need to bring it down below 140/90 to reduce your risk of a stroke or a heart attack." Even though Geraldine says she will take the medicine, do we really believe that this will happen? And will she ever want to work with this healthcare professional again? Probably not. In this case, the issue is addressed in such a threatening way that it might provoke Geraldine to conclude, "I'll be darned if I'm going to listen to her. She's going to talk to me like that." Again, rapport and addressing the issue are really inseparable. Here's the fourth style of interaction, MI, that emphasizes both addressing the patient's sense-making while also building rapport with the patient.
I don't know. I just don't think my blood pressure is that bad. Lots of people have worse blood pressure. And also, I just don't like taking medicine.
You're thinking that your blood pressure is not all that high, especially since other people have blood pressures that are much higher. Not only that, you don't like taking medicine.
Right. Patients are prescribed too much medicine all the time. Besides, I feel okay.
You worry that sometimes medicine is prescribed that may not really be needed, and you feel okay, so maybe the medicine is really not necessary.
You got it.
You raise a lot of good points. Would you mind if I shared some thoughts and you tell me what you think?
I suppose.
First, I sure don't want you to take any unnecessary medication. While you're right that your blood pressure may not be as high as other people, the problem is that we never know what level of elevated blood pressure can cause you to have a stroke or heart attack. If you think of your blood pressure as a fuse and stroke or heart attack as the explosion, we simply don't know how long your fuse is, and there are many factors that can affect that. What's worse, you may not have any symptoms until you have a stroke or heart attack. This medicine can help protect your fuse to keep it from burning down prematurely. hence greatly reduce the chance of stroke or heart attack. You have to decide how important it is for you to reduce your risks of your fuse burning down. The medicine can really help that. Where does this leave you now in regard to taking your medicine to reduce your risk of stroke or heart attack?
Well, no one ever explained it to me that way. I don't want that explosion to happen.
I don't either.
Okay, I guess I'll take the medicine. And you think it can really help?
Absolutely. It can really bring down your blood pressure and reduce your risks of stroke or heart attack.
Okay, I'll take it.
In this interaction, not only does the healthcare professional explicitly reflect the patient's sense-making, she reassures Geraldine that she doesn't want Geraldine taking medication that's unnecessary. After asking permission, the healthcare professional uses an analogy to provide information that directly addresses Geraldine's issues, that her blood pressure isn't that high and that she feels fine. Implied by these statements is Geraldine's sense that she isn't at risk if her blood pressure isn't that high, especially since she feels fine. Therefore, new information to directly address the patient's issues must address how she can feel fine, have blood pressure that is not that high, and still be at risk. The analogy about a fuse and explosion really helps to make this point for the patient in a way that makes sense to the patient. We will further discuss the use of analogies in a future module. One last point is really important. Did you notice that the healthcare professional tells the patient, you have to decide how important it is for you to reduce your risk of your fuse burning down? This puts the decision squarely where it belongs, with the patient. It's her high blood pressure and her risks. So with this new information, she has to decide if she'd like to take the necessary steps to reduce her risks. As a result of explicitly reflecting and directly addressing the patient's issues, while maintaining rapport, Geraldine has now reconsidered taking the medication. There's no face loss, hence no relational resistance. There's positive affirmation of Geraldine as a person, hence increased rapport. As a result, Geraldine listens to the new information and reconsiders her decision about taking the medication. What do you conclude from these 4 examples? Hopefully that the possibility of real sustained health behavior change only occurs when we treat the patient with care and respect, accurately reflect the patient's sense-making, and address the patient's issues. This is exactly what happens with MI. Okay, here are your first questions for this module. Here's an example of a healthcare professional who explores and engages the patient's sense-making in a very judgmental manner. Notice that the healthcare professional listens closely enough to identify and refute the patient's issue with another medication being added. Because there's little rapport built here, this interaction is definitely not MI.
I hate that he's added another medicine. He says I need it to control my blood pressure. I just don't like it.
Did you discuss this with the doctor?
Yes, but he said I need the extra medicine.
Did he tell you why?
Yes, he said my blood pressure is still up, and then he scolded me and said if I lost about 30 pounds, I might not need the extra medicine.
Well, there you go. Are you going to lose the weight?
You sound just like my doctor. You all make it sound so easy to just lose 30 pounds.
Do you want to lose the weight or take the medicine?
Thanks. Just fill my prescription.
In this encounter, the healthcare professional uses a cross-examination style of communication. Just about everything this healthcare provider says is in the form of closed-ended questions that are searching for information to shoot down the patient's thoughts and feelings. Notice that the patient starts off this dialogue by expressing his hatred that the doctor has added another medication. Instead of acknowledging the distress of the patient, the healthcare professional asks two closed-ended questions and then judgmentally exclaims, "Well, there you go." With this, the healthcare professional indicates that the problem is with the patient, not with the doctor. Then the healthcare professional follows up with two more closed-ended questions that imply the patient will more than likely be non-compliant. Note that the healthcare professional has elicited a lot of information from the patient, but it has been used to judge the patient and put the patient in his place. No wonder the patient winds up defensive and withdraws from the interaction. Notice that the patient's strong feelings about the added medication are neither acknowledged nor explored. Consequently, the patient doesn't feel understood, nor does he feel like he has an ally. In fact, the patient says, "You sound just like my doctor," and implies that he doesn't understand either. Because the healthcare professional has relied so heavily on judgmental reflection and cross-examination, the discussion hasn't even gotten close to the fact that this patient is not necessarily questioning whether losing weight would help lower his blood pressure. He seems to understand that lowering his blood pressure is important and that losing weight might be a better way to accomplish this than taking medication. It's just that he's not confident that he can lose the weight and keep it off. Here's an example of appropriate rapport building based on non-judgmental, empathic reflections of this patient's sense-making.
I hate that he's added another medicine. He says I need it to control my blood pressure. I just don't like it.
It seems like the doctor just keeps adding medicine to control your blood pressure, and that worries you.
Exactly.
Tell me more about what you don't like about the doctor adding another medicine.
It seems like as I get older, I have to take more and more medicine.
Growing older and having to take more medicine has been difficult to accept. Perhaps you're even wondering if more medicine is really necessary.
Yes, exactly. Plus, does this mean my blood pressure is getting worse?
So it's both wondering if you need all this medicine and are you getting worse. Both of these have you feeling pretty anxious.
Right.
What have you discussed with the doctor regarding these concerns?
He said if I would lose 30 pounds, I might not have to take so much medicine. Like it's so easy to lose 30 pounds.
Losing weight, especially 30 pounds, seems like a lot of work and quite difficult, even though it might result in less medicine.
You got it. Either lose more weight or take more medicine.
Neither seems very attractive right now.
No, they don't.
It sounds like you aren't questioning whether your blood pressure has gone up. You just don't like either solution for bringing it down.
Right. I don't want to have a stroke or heart attack. I just wish I didn't need more medicine or have to lose weight.
Let me ask you something. If you could wake up tomorrow morning and snap your fingers and be at the weight you would like to be at, what would you like about it? In addition to lowering your blood pressure and reducing your risk of stroke and heart attack, what else would you like about losing 30 pounds?
This healthcare professional is doing a great job of reflecting the patient's concerns in a non-judgmental way. He hears the patient express worry about the addition of a new medication and uses an empathic reflection to surface that worry. Seems like the doctor just keeps adding medicine to control your blood pressure, and that worries you. In addition, the healthcare professional explores the patient's concern about taking more medicine. Tell me more about what you don't like about the doctor adding another medication. The patient offers additional information that ties the need for more medication to his getting older, precisely because he feels safe and understood. The healthcare professional offers an empathic reflection. Growing older and having to take more medicine has been difficult to accept. Then the healthcare professional explores an issue that has been implied but not stated. Perhaps you're even wondering if more medicine is really necessary. The patient continues with an emphatic affirmation of this concern. Yes, exactly. Notice that the patient then adds another concern. Plus, does this mean my blood pressure's getting worse? Instead of immediately proceeding to answer this question, the healthcare professional continues to build rapport with the patient by summing up the two questions that the patient has expressed. So, it's both wondering if you need all of this medicine and are you getting worse? Then the healthcare professional empathizes with the patient's feelings by saying, both of these have you feeling pretty anxious. It's important to recognize that by reflecting these two concerns and by empathizing with the patient's worry, the healthcare professional has formulated a non-judgmental summary of the patient's experience. This goes a long way to establishing rapport with the patient. When the patient answers right and doesn't provide any additional elaboration, the healthcare professional has evidence that the patient feels understood and respected. At this point, it's possible for the healthcare professional to explore what the patient discussed with his doctor regarding these issues. Instead of the patient focusing on his concerns about the doctor, the concerns have been reframed and refocused as his concerns about his medicine and his blood pressure. This reframing would not have happened without the reflecting and empathizing of the healthcare professional. As the patient repeats his dissatisfaction about it not being easy to lose 30 pounds, the healthcare professional avoids disagreeing with the patient by continuing to empathize with the effort required. The strategy continues for 2 more interactions. The patient expresses his dissatisfaction with both the medicine and losing weight. Both times, the healthcare professional reflects or empathizes with the patient. Once again, the patient affirms the last empathic reflection and then adds some new information. Right. I don't want to have a stroke or heart attack. I just wish I didn't need more medicine or have to lose weight. At this point, the patient has expressed his dilemma in his own words. What would have happened instead if the healthcare professional had said, look, if you don't want to have a stroke or heart attack, you have to take more medicine or you have to lose 30 pounds. The patient would have lost face and become even more resistant. Because the healthcare professional has worked to create deep rapport, the healthcare professional can prompt the patient to consider the larger balance of pros and cons. In this case, the healthcare professional uses a skill called a look over the fence to prompt the patient to consider other benefits of losing weight that haven't been talked about yet. It will now be the patient who talks about the benefits of losing weight, not the healthcare professional. This skill will be discussed further in a later module.